Dr. William Zoghbi, and I want to welcome you to our weekly cardiovascular imaging conference. I think this is the start of the academic year, and we usually go through the basics of all the images that we acquire, be it echocardiography, nuclear, CT, MRI, and all. And I'd like you also to interact with us, so please send your questions. Text it to DeBakey, D-E-B-A-K-E-Y, to 37607 and ask your question. I will be happy to answer those questions. So let's get started. We're going to talk today about Doppler basics and physics. I know it may be boring to some of you, but I think it's important for us to go from time to time to the basics of how the image is constituted, the evolution of echo Doppler techniques and how we use them nowadays. But mostly I think it's good to refresh ourselves as to the basics, because then we can understand the artifacts, some of the issues that we're dealing with. So I think it's a good basis for us to review together. So echocardiography, for most of you, is really a mature technology that has evolved into techniques from M mode to 2D, 3D echocardiography, and the various Doppler evaluations that we have to deal with. And I think each one of them is amazing in a way, because all of them depend on these small packets of ultrasound that are sent. They reflect back to us, and then we ask the question: is it how far is it? How intense? Did the frequency change when we send it back? And these are the basis of imaging and ultrasound. So in ultrasound, you have to think about the wavelength, and the wavelength and the frequency of that is the number of cycles of these over per second. The longer the wavelength, obviously, the lower the frequency. The shorter, the higher the frequency. Remember the speed of ultrasound in biological tissue, 1540 meters per second, and that's how we calculate the depth of a particular object that we image. And properties of reflection, refraction are similar to light. So if we take the transducer, we send usually small packets of ultrasound, and they are in the ultra range, so we cannot hear them because they're in the megahertz range. If they reflect a surface, whatever that surface is, this is where the beam is going. Some of it is refracted, and we're not going to see that. Some of it is reflected in a symmetrical fashion, and we don't see that because it's not captured by the transducer. So what you see is that little tiny fraction that comes back perpendicular in the same direction that you sent it out, and the image is processed. So that's how the images are processed. We send bursts of packets of ultrasound for you to be able to reflect it back and ask the question of how deep is it and everything else. And if it is more reflectant, it will have a higher intensity and therefore more dense. If you turn this back from an A mode to a B mode, so you reflect them 90 degrees back, then you'll get a more reflectant area, and that's what we use nowadays for 2D and 3D. For you, for M mode, right, M is for motion. So if you have a certain dot, and then the scale is time, if there is no motion, it will be a straight line. If this motion goes up and down, let's say the mitral valve is going a little bit up and then down, you're going to see it going up and down. And that's what an M mode, the beauty of an M mode is, it has a great time resolution. So you can take a look at really every little tiny detail of its motion, and we use that nowadays for a few things. If you want to address a motion of a particular subject, the motion of the mitral valve, few things here and there, but for measurements, obviously, we prefer to go to 2D. And this is a 2D examination. The question is how do you make this image? And these are actually from steering the beam from the ultrasound, these crystals that are piezoelectric crystals that are deformed with electricity and send the ultrasound wave. So you can have so many scan lines along the line there with some interpolation. But notice also that because of the ribs the way they are, we have to image in between them. So for echocardiography, it is more of a V-shaped scan as opposed to linear, where in the other parts of the body we don't have much interpolation of other areas that reflect too much ultrasound. Notice also that they spread further. If you go further down, they'll spread further, and this is some of the part issues of the lateral resolution that occurs with this kind of scanning. We think also of two kind of resolutions, at least for 2D. Axial resolution in the line of the transducer beam or the ultrasound beam. The higher the frequency, meaning the tighter these waves are, the better the resolution. So you can differentiate one dot from another. And the slower the frequency, the lower the frequency, these two dots may not be differentiated, and there will be one. So one important message here is use as much higher frequency transducer for you to have the best resolution, axial resolution. Also, this is the best resolution, so meaning if I want to look at the septum or let's say an interatrial septum defect, the best is perpendicular to that structure, so a subcostal is really the best way to do that. So the more perpendicular you are to an object, the better the resolution. This is lateral resolution, will depend on the beam width. As you go further down, you can focus some of these beams and hopefully differentiate these two dots from one to another. The further out you go, certainly you're going to have more of a globular-like look, because you're not able to differentiate, these two dots from each other, and you could see that in the further distance. These are some of the important instrument controls: overall gain, time gain compensation, lateral gain compensation, reject compression, and then mechanical index. All these first 1, 2, 3, 4, 5 are post-processing, meaning that is after the ultrasound wavelet has come back to the transducer, and you're processing this by either increasing the gain, a reject, and compression. This is the energy that is sent to mechanical index and output power of the ultrasound that is regulated to keep safety on board, but also that's the one that we have to keep in mind when we use for imaging of contrast, so we don't destroy these tiny microbubbles. And this is the mechanical index, peak negative pressure divided by the square root of the frequency. So for ultrasound bubbles, obviously the higher the mechanical index, the more stretch these bubbles have, and the more destruction you have some of these bubbles, going forward. Few other things that we notice during examination: reverberation and attenuation. This is attenuation, meaning that the wavelets are coming here, most of them are reflected back, and then you have a shadow behind it, completely shadow there, because if the ultrasound is not penetrating further down, you're not going to be able to reflect much for you to be able to see. This also happens, the same thing for Doppler. This is the reverberation, actually. This is not shadowing. It is interesting finding here at times in certain structures or mechanical prostheses at times. The ultrasound reverberates between the two, metal areas of the prosthetic valve, and you see this shadowing in a way, but it has a little different look of reverberations, and this is what you see. Now, at times you see a lot of crowding of the ultrasound, particularly in the near field of the transducer itself, and you wonder whether this is a thrombus clinically or this is an artifact. And for you to differentiate that, if you don't have contrast, you change the transducer, because it may have to do with the casing. Have a different window, go up a little bit and go down towards the apex itself. Change your window to try to avoid that. But nowadays, actually not infrequently, we'll use contrast to try to help differentiate this area. So you could tell here that it would be very hard to tell whether this is a thrombus, but you could see that very nicely when contrast is used to demarcate it. So technologies over the years have evolved so much. We don't want to date ourselves back, but we can remember the video days to digital days, very high frame rates, which is amazing. Multi-frequency transducers. In the past, we had to change for each frequency, change the transducer. Harmonic imaging we'll talk about, because it improves images as well as contrast. Tissue Doppler, digital image storage, and real-time 3D echo certainly have evolved significantly over time. and you could really enjoy all these developments nowadays. Harmonic imaging. So you send a certain frequency, and usually there, a certain, let's say a 3.5 megahertz frequency. This is called the fundamental. But whenever you hit an object, or it may resonate, so you have multiples of that frequency, 2 times fundamental, 3 times, or even ultra frequency, or lesser, almost half of that. And why is it important? It was an interesting discovery that actually native tissues will emit harmonics, which is a multiple of that ultrasound frequency that you're sending. And actually, by using a harmonic imaging, meaning I send a certain frequency, but I image at multiple of that, I could decrease some of these reverberations that you see and improve image resolution. It's also better for visualization of contrast, because when contrast is hit with these fundamental frequencies, they vibrate and emit resonant frequencies. So if I image using my resonant frequency, I'll enhance that signal coming back from contrast itself. Okay? So this is an example of harmonic versus fundamental in the same patient. Here you can tell whether this is an artifact or not, and here you could tell that this is an apical hypertroph, as opposed to a lot of crowding here that you can't see too well. The other use obviously is for contrast itself. Notice now, this is a contrast has been injected, it's filling the ventricle, but I cannot differentiate well from the contrast per se from the myocardium here per se. And notice that if I turn on harmonic in this individual, I enhance significantly the contrast itself compared to the muscle itself. And this way you have this nice contrast enhancement to be able to evaluate ventricular function, whether there's thrombus, etc., etc. So you have to keep those in mind when you image a patient and you use contrast, to use the right settings for it. And another thing is that for optimization, and we'll talk about that in other contrast, is you want to make sure that the mechanical index, the MI, is not too high. Otherwise, you're going to destroy quite a bit of this contrast and may not see things as well. Switching on to Doppler. For Doppler, there are a few concepts that you need to know. Pulse wave Doppler, be it spectral or color, or continuous wave Doppler. And this is in Salzburg, Austria, when I visited many times, and this is actually the birthplace of Christian Doppler, who is the inventor of Doppler effect. Just imagine back in the 1800s to be able to do that, from looking at the stars and the Doppler shift of color that we're seeing and coming up with the Doppler equation. It's really amazing to be able to do this. And the principle is simple, is that if you have a certain frequency and that frequency is moving, or you moving in relation to that frequency, there is either compression or decompression of these waveforms. So it would be either a higher frequency or a lower frequency. And it relates also to the velocity of that object. So the best example usually we take is a siren, and you're standing on the street, and the ambulance comes over, and you could tell if you close your eyes that indeed that ambulance is coming towards you. So you could tell that because the pitch goes up higher, and then you could tell even that it is going away from you because the frequency will come down. Interestingly enough, if you're far away and perpendicular to the trajectory of this moving object that is emitting a sound, you may not differentiate it because it's almost perpendicular to that frequency itself. So that's the basic principle here, right? So you can tell by Doppler, you can tell whether it's a velocity that's coming towards you or going away from you. And also, this frequency shift relates to the cosine of the angle of what you are imaging with the motion of that particular object. And most of the time here, it's either blood in the cavity, and more, as of late, more muscle and tissue Doppler. So in the past, the echo machines used to display the change in frequency, and you had to kind of convert it, if you will. But most often nowadays, and actually pretty much everywhere, you will see a velocity scale, and cosine theta is assumed to be the angle of the ultrasound with the motion is assumed to be 0, so this would be 1. So therefore it relates to the frequency shift and the initial frequency, the emitting frequency, in addition to the velocity of tissue and the medium, the biological medium. So most of the time it is acceptable if you have, you know, an angle below 20 degrees. Once it becomes greater than 20 degrees, I think you will underestimate the frequency shift and therefore the velocity. Okay, so let's talk a little bit about pulse Doppler. This is the spectral display. And the beauty of pulse Doppler is I have an area of interest that I'm interested in finding out what the velocities are. So I send a packet of ultrasound, like this one here, and I won't listen to it, see what happened to it, I'll let it go. I know what the distance is going to be, meaning the time that it takes for it to get there, and I'll wait for it to come back, so double the distance from the transducer all the way down, and then I listen to that. And I listen with the question of how much frequency shift has occurred between the fundamental frequency and what came back. So if it is higher frequency, you know, the velocity is coming towards me of that object. If it is lower, it's going to be going away from me. So I can range gate, I can find out where it is. And the problem with it, since it is almost stroboscopic, you're not going to be able to resolve very high velocities. Example of pulse Doppler, this is pulse Doppler in the LV outflow tract. Most of these red cells are going at the same frequency and same velocity. Then there is some dispersion here because not all of them are going at the same speed, and then deceleration. So this is your pulse Doppler in the LV outflow tract. This is mitral inflow, and with all the applications that we have, diastology, outflow, regurgitant volume, regurgitant fractions, everything else. So this is what we call spectral broadening. And the way we solve for this equation is the fast Fourier, which is probably among the best equations to this complex frequency shift that occurs. Aliasing is the phenomenon where I cannot resolve what these velocities are, and they look like basically bands of frequency shift, and I really cannot tell what they are. And it depends on the pulse repetition frequency. It's almost like a stroboscopic thing. If you're in a nightclub and a moving object, and you can't tell whether this individual is going in the right direction or opposite because you're seeing only few pieces in time overall. Okay? So now if the frequency shift is not too high, you could do a baseline shift, bring it up and down so you can see almost double of that Nyquist limit that you're dealing with, and that's what we do nowadays. So this is an example of aliasing, meaning a mitral inflow velocities are low. I can differentiate them and look at the time of their distribution. Here, this is mitral regurgitation. As you know, mitral regurgitation jet is a very high velocity. I'm not going to be able to differentiate this, so it looks like a very aliased, basically signal. I'm not going to be able to help me, but I know that at least it will exceed that velocity by that much. Color Doppler is, in a way, a pulse Doppler technology, but not enough time to be able to resolve a fast Fourier transform. So we have an estimation of actually what the velocity shift is occurring at these tiny, tiny little windows, and therefore we can tag them with a direction coming towards me, more red-yellow, going away from me, from the transducer is bluish. And if we have aliasing, basically you're going to have a mosaic of these colors, you know. But as you can tell, the aliasing frequency, and the recommendations usually is to use about 60 cms per second Nyquist limit. So you're going to see, you know, a higher incidence of aliasing with color Doppler technology used for identifying where abnormal flows, and this is mitral regurgitation. We'll go through a session for that, and where the flows are, and maybe detection where some of the abnormality of flow is. Notice that you know, it still has the same principle of Doppler. So therefore, let's take an example. If there is a change in direction of flow, you're going to go through a period of blackness, meaning no frequency shift. So this is an ascending aorta, reddish colors coming towards you with a certain velocity perpendicular to flow, becomes no frequency shift because cosine theta of 90 degrees is 0, then it starts getting blue. So this is how you can tell difference between aliasing versus a direction of a change in directions. What are the factors that will influence color Doppler? Gains, obviously, color maps, frame rate, and a Nyquist limit. This is just a higher gain, and you could exaggerate in aortic regurgitation and mitral inflow coming through here. So Nyquist limit is very important, because if I decrease my Nyquist limit in this mitral regurgitation to the 20s, I'm going to detect almost any flow that is occurring here and will exaggerate what mitral regurgitation looks like. This is the same patient with a more appropriate Nyquist limit, usually above 50, between 50 and 70, and you could see the mitral regurgitation. A little swirling, but certainly looks very different. So you want to make sure that you have the appropriate Nyquist limit, that you don't use a low one that somebody else may have brought it down significantly and overestimate. And we've had some examples in the operating room where we were called to say, well, this patient may have significant mitral regurgitation, and indeed there was a Nyquist limit difference that you saved somebody's intervention. Now, frame rate is important here because you have a significant section to process all this information, and we want to make sure that you have the frame rate that is appropriate, so that in a way you can get to almost real time, right? You don't want the frame rate to be too low meaning below 15, probably certainly 10 and below is too low. You're going to have some almost stroboscopic view of regurgitation. So you want to optimize it, and part of the optimization is to make sure that your width of color is really not too wide. So the frequency, yes. Scan depth, now here I cannot play around with that scan depth. That's what I need to assess mitral regurgitation. Width of color region, and still use your judgment as to what area I really need to see. The line density, and that's usually, we don't play that around, is how many times a scan line is used for processing of color before going into another one. High pulse repetition frequency, same principle in a way. I know at times we're not going into it nowadays because we have continuous wave Doppler, but basically it's multiple areas of interest, and basically the advantage of that is for you to be able to use resolve a higher frequency or higher velocity, like in the old days of aortic stenosis where we used this. Nowadays I'm not going to go through it anymore, just for the sake of time. Continuous wave Doppler, as opposed to pulse Doppler, where you send a pulse, you wait for the range of the depth that you want for you to listen to it and listen to that. Here is, you have a crystal that is sending continuously your frequency and a crystal that is listening continuously back. So you could tell what the difference is going to be. The difference is I can interrogate all these velocities along that line, and the highest one will be demarcated. So this is an aortic stenosis jet. You could see that very nicely here. These are the velocities most likely in the LV outflow or in the ventricle itself. So remember, CW is along any of this here. So at times you may have an obstruction in the middle of the cavity, and this is the highest velocity that you can have. So you have to interpret that accordingly. Tissue Doppler, a signal that we've ignored many, many years now. We've had it, I guess, 15 plus years ago now. We ignored it because it was more of a noise thing, and we were much more interested in the Doppler and the velocities of the red cells themselves in the ventricle, but turned out that there's a lot of information in that. Interestingly enough, you can differentiate them very nicely. Why? Because the velocity in the myocardium is much lower than that of blood flow itself, and also the intensity of the signal is much higher. So you could put your filters one way or another. I want to see muscle, tissue Doppler, or blood, regular Doppler. And the applications, quite a bit of that, of of diastolic function and so many other things. And speckle tracking is another technology that is really amazing, actually, is to be able to track these speckles of ultrasound that are reflected back to the transducer. And part of the major advantage of this speckle track is the ability to look at deformation, not only in the usual way in the past that we used to take a look at, which is thickening of the myocardium from the peristernal long axis where you're perpendicular to the structure. Here you could look at deformation and thickening and thinning in almost any window. And what is strain? Strain is how much deformation has occurred compared to the baseline. So if you have a 10 centimeter that has shrunken down to 8 centimeter, you have a strain of minus 20% because you decreased. If it's stretched, it'll be greater than basically a positive number, 20%. If there's no change in strain, is down to 0. Strain in the past was initially developed with Doppler technology. Unfortunately, with Doppler, with 2 samples here, whenever you have a curvature or an angulation, you will underestimate it. The beauty of speckle tracking is angle independent, and that's where quite a bit of the applications for systolic, diastolic function, and you name it, is important. Strain rate, we don't use as much because of noise, and hopefully that will improve over time. Although you may have the same strain that has occurred from a point of time to the next one, you can have much faster strain rate to achieve that same deformation. That tells you a lot about systolic function or diastolic function. It has some of its applications, but it is a bit noisy, and that's why you go throughout the period of the cardiac cycle that you're interested in, meaning strain as opposed to strain rate per se. Okay, different types of strain. The longitudinal one that we use most of the time, which relates to the descent of the base, but regionally as well as globally, right? The GLS. Circumferential, radial, which is radial shortening, and these are the things. And this is an example of a normal strain and strain rate, and you could see that you could address not only the global one but also regionally, and this is fully automated, really a beautiful application of speckle tracking technology. And normally for a GLS is lesser than minus 18%. Basically deformation in systole is minus 18, minus 19, minus 20, etc. And this is a very abnormal heart, obviously, with a GLS just minus 2%. I mean, dramatic from normal to very abnormal. Digital image storage. I know it is for granted nowadays. You take that for granted. But let me tell you my feel about the importance of that. This occurred, around year 2000, so 20 years plus of digital image storage. The beauty of it is, remember, echocardiography is very tomographic, and it is very dependent on the person who basically takes these images, right? And that brings about a lot of variability and brings about, said, if I need to measure something, which is the view that I need to measure it at? The beauty of this digital imaging and display, as opposed to a single beat, you can have 4 beats at the same time or even 9 beats, that's what I enjoy most of the time, is you could quickly take a look at this heart itself and at the same decide which one of these views are best for measurement. And you could take a look at that. And these are different short axes at close to the mitral valve, papillary muscles, in the apex without any papillary muscle, so you can decide quickly. If a view is foreshortened more than others, you could see a lot of papillary muscle here and chordae tendineae. Maybe that's not the best for you to measure the diameter of the ventricle by 2D, irrespective. More importantly, even from the apical window, to measure your volumes and ejection fraction, which is less foreshortened. So you can compare them together. And that's the beauty of having multiple views of a digital image. And I think, we take this for granted, but I think this is very important. And part of the, obviously evolution of echocardiography is the application of 3D. I wanted to share with you, this is actually among our first images here back in 2003. So we're talking about 17 years ago. From a 3D point of view, and you could take a look at that. And certainly things have evolved over time to a single beat image as opposed to stitching. At times we still have to do stitching for this heart to be able to take a look at the whole volume, volumetric. Major applications nowadays is to take a look at volumes of this heart, ejection fraction, at times mitral stenosis area at the tips of the mitral valve, and some of the regurgitant lesions. Things have evolved significantly over time. We have now high volume rate, 3D imaging that can help us significantly, and I think we need more and more of these applications for better ejection fraction and volume estimation. We still, the same limitations, if you will, for echocardiography will apply to 3D. So if I have a poor image by 2D, you're going to have a poor image by 3D. But importantly, it will avoid quite a bit of the foreshortening of the apex. And image optimization is still very significant there to be able to do that. You could do 3D global regional strain also. And some of the beauty of applications are for valvular heart disease. Nowadays that you use this in the interventional arena, interventional imaging, in addition to just to identify where some of these abnormalities are. Yes, the time as well as spatial resolution of 3D, be it whatever methodology, is a little still less than 2D imaging. But the beauty of 3D is at times it may localize things in the 3D space that 2D may not tell you the whole story. So I know, particularly for mitral valve pathology, 3D ultrasound is really very important to tell us, particularly from the transesophageal approach. This is 3D color Doppler. Yes, it is impressive that you could take a look at the whole jet itself, but some of the quantitative parameters are those for vena contracta and some of the PISA calculations for color Doppler, meaning the flow conversions coming into the mitral regurgitation, much less of the volume of the jet itself. And I think last year, among the first clinical experiences, I think reported by Roberto Lang and his group, was a different way of showing the images with transillumination rendering. It looks quite impressive. It is very nice to be able to see that, and the image is almost like you're looking at the mitral valve per se in front of your eyes. So it is quite impressive of how much have really come along from the days of early echocardiography. A timeline of our evolution from the early Dr. Edler's applications on mitral valve, A-mode technology, M-mode technology, 2D, Doppler, color, TE, contrast, tissue Doppler, live 3D, speckle tracking, and handheld echocardiography, basically the same principles there. Really quite an evolution, based still on the same principle of sending ultrasound waves and processing whatever is reflected from the object in the transducer, taken up by the transducer because it excites the transducer, and then go back and process, with all the computerized technology, process this. I want to share with you last is actually, this is a video back in 1960, so we're talking about, my goodness, quite a few years ago now, 60, 70 years of Dr. Engi Edler doing an initial examination. Dipping the transducer, and that's Dr. Edler himself. And you'll see the A mode. There you go. So this is the mitral valve, and certainly has our visualization of the heart with ultrasound has improved so much, still on the same principle. So certainly we can't be more thankful for Dr. Edler to introducing this in the clinic. and gradually, with all the computing technology, to be able to render these images almost like in real time, for us to be able to evaluate heart disease, its application of the technology, and management of patients. So I'm going to stop here, and let's see if we have some questions. I know it's been through quite a bit here, but it's good to reflect back and think about some of the basics of ultrasound and how to avoid some of the pitfalls and improve the images. All right. And I think if no questions, it's a pleasure having you, and look forward to seeing you in our weekly conferences. So thank you again for joining us.